Hi and welcome to Airwaves, the Safe Airway Society live stream. Today we're talking capnography, its role, gaps in access, pitfalls in interpretation, training in its proper use, and of course the international consensus guidelines for preventing unrecognised esophageal intubation. I'm Nick Chrimes.
And I'm Kirstin Fraser. Today we're joined by Tim Cook, Alan O'Sullivan and Jan Hansel as we discuss why capnography is essential everywhere.
Hi and welcome to the show. First off, I'd like to introduce my co-host Kirstin. Kirstin's an anaesthetic technician in New Zealand. She's the past chair of the New Zealand Anaesthetic Technician Society and the current secretary of the Safe Airway Society and a member of the advisory group to PUMA, the Project for Universal Management of Airways. Welcome, Kirstin.
Thanks, Nick.
Just first up, if we have technical issues and the live stream drops out, I'm not sure that this same link will pick up again when we restart. So if it does drop out, give us 10 minutes and on the Safe Airway Twitter account, I'll retweet out the new link. Hopefully that won't be necessary. But at Safe Airway is where to go if we have a catastrophe. Follow the Safe Airway Society on Twitter while you're there. I'd like to thank our sponsors today, Verathon and Lateral Medical, and just make the point that the sponsorship funds all go to the Safe Airway Society. Neither the hosts, myself or Kirstin, or any of the other panel members are receiving any remuneration for their appearance today. They're coming in their own time and expressing all their own opinions. We want this to be an interactive session, so log into YouTube. If you're logged in, you'll be able to submit comments. You can if you've got questions, put a Q in front of your comment so we know that it's a question, and we'll put those questions to the panel in real time. And afterwards, if you want to continue the conversation, I'll put up the Twitter handles for our guests, and you can continue the conversation using the hashtag AirwavesCO2. And finally, I just encourage you to join the Safe Airway Society. A lot of these free events are funded in part by membership fees, which are very reasonable, so we just encourage you to support the society. And I'll get Kirstin to introduce our first guest.
Thanks, Nick. So it would take the whole show to do our first guest's biography justice. He's an anaesthetist and an intensivist at the Royal United Hospital in Bath. He's been involved in nearly all of the UK national audit projects, most recently the just published NAP7 on cardiac arrest. He's the Royal College of Anaesthetists Advisor on Airways and one of the lead authors of the International Consensus Guidelines for Preventing Unrecognised Esophageal Intubation. Please welcome Tim Cook.
Okay, now Kirstin, I'm just going to say to you.
Hi Nick, thanks very much.
Thanks for joining us, Tim. You've gone very clicky and funny in your camera, Kirstin. It might be worth you just logging out and in again, or turning your Wi-Fi on and off, or whatever you did yesterday to fix that, because you've gone very strange at the moment. Anyway, I'll just oh, that was that was dramatic. I'll just introduce our next guest. So our next guest is equally hard to do justice to her achievements. She's an anaesthesiologist at St James Hospital in Dublin. She's a past president and airway advisor at the College of Anaesthesiologists of Ireland and past president of the Difficult Airway Society. She's a member of the Global Capnography Project and one of the authors of the guidelines for the Project for Universal Management of Airways, and particularly the esophageal intubation guidelines are relevant today. Please welcome Professor Ellen O'Sullivan.
Hi, Nick. Nice to be here.
All right. Now, I'm just checking if we've got Kirstin back. Hang on. Yes. And moving in real time now. That's good. Okay. Just in time to introduce Jan, Kirstin.
Oh, perfect timing. Okay, so our final panel member is a senior trainee in anaesthesia and intensive care medicine and the lead author of both the Cochrane Review comparing video laryngoscopy to direct laryngoscopy and the systematic review and meta-analysis on the usefulness of clinical signs for excluding esophageal intubation. Please welcome Jan Hansel.
Hi, Jan. Good to see you.
Thank you both. Thank you for the kind introduction. Thanks.
Okay. Let's get into it. So before we'll certainly end up talking a lot about unrecognised esophageal intubation, but before we do that, I wanted to get into the broader role of capnography beyond confirming or excluding esophageal intubation, and particularly, I think, Kirstin, you wanted to ask a bit about modes of CO2 detection.
Yes, Nick. So this question's for Ellen. There are other mechanisms for CO2 detection, such as colorimetry. Why is the emphasis specifically on capnography as the ideal method, and why is it so important?
I mean, capnography is the gold standard. It's the most reliable, and it is a continuous. It's a waveform we need. We need this kind of. We need the continuous waveform facility. Capnometry is unreliable. If it gets wet, it doesn't function as well, and it doesn't give you the waveform that we need. And I think, as we know now, it's sustained exhaled CO2 we're interested in, and that's very important. So capnography is the gold standard. I think we should use the best. It's an essential monitor, and I wouldn't compromise. I know in A&E departments, and even at times in low-income countries, they've tried it, and in fact, I've not seen one there in years. They're so unreliable, and they're not used.
Yeah. And
Not very
anyone else got any
scientific, but
comments about?
that's the.
Sorry, Alan. Anyone else got any comments on capnography versus colorimetry?
Yeah, I'll come in. I think they're a world apart, really. Capnometry seems to be so color change capnometry. These funny little light purple and yellow change devices, which are particularly popular, I think, in neonatology, and sometimes in some locations in ED, and I think in certain countries. I think that one of the problems I think with them is they've got lots of opportunities to go wrong. So I think in low in circumstances of low instant light, they're difficult to read. If the color change is not very much, so if on a capnograph your CO2 amplitude would not be very high, then you don't get much color change, and so it can be difficult to read. So if you've got a lowish cardiac output, or poor perfusion of the lungs, so for instance in pulmonary embolus, and therefore you've got a low end tidal, then you may not get a positive. You may not get clear color change. It may be confusing. Similarly, if you've got at birth, if you've got contamination with gastric acid or with meconium, you can get false positives. So I think they've got lots of flaws to them, and I think they tend to be used as a device for saying, well, let's plonk this on, let's confirm we're in the right place and take it off again. Have we got a colour change? Yes, now that's worked. And I'm kind of thinking here of, say, the InTube study. Whereas what you really need is a continuous monitor of exhaled carbon dioxide. And I think really only capnography, waveform capnography, can produce that. I mean, I'm old enough to have started anaesthesia when I started anaesthesia in 1988, last century, well into the last century, there was one capnograph for the whole of the theatres that I worked in, and there wasn't actually any oximetry in the first year I was there. And the capnograph was a voltmeter or amp meter, and so you had a needle that swang to and fro, and so you could see a sort of a sweep of respiration going on. But we are so blessed to have capnography, waveform capnography, that works in almost all settings, including down to very small neonates, used more widely for transport than it is for in NICUs, certainly in the UK. We're very blessed, and we really ought to use that opportunity, not just for confirming intubation when it occurs, but also for monitoring the position of a tube after intubation.
Great. I've just put up that table there, which was a table that was left over from the they're preventing esophageal intubation guidelines that we had to pull out, and I'll pop that up on the show notes after, if people want to have another look at that. Tim, another question for you. I think I've heard you refer previously to the fact that we need to think about capnography as, whilst it provides information about breathing and circulation, that we need to think about it primarily as an airway monitor. I was just wondering if you could expand on what you mean by that and the significance of it.
Yeah, so if I was given one of those exam questions where they asked me to identify the various phases of the capnograph, the A, B, C, D, I think they referred to that, or was it phase 1, phase 2, etc. I'm not even sure. Then I would fail that test. The capnograph has value at the point of intubation, and when monitoring correct or incorrect position of a tracheal tube, or of ventilation through any other device, supraglottic or face mask. It has a value as a airway monitor. So is the tube in the right place? And particularly for excluding esophageal intubation. It has as an adjunct, it can have value as a respiratory monitor or as a monitor of the adequacy of chest compressions during cardiac arrest. But I think it's important when one is considering tracheal intubation, the potential for esophageal intubation, distinguish between the two, to very clearly focus on the fact that at the point of intubation and when monitoring the airway, it is an airway monitor. The fact that there's a gap between the end tidal CO2 and the arterial or the alveolar or the arterial CO2 doesn't matter. It doesn't matter that it's a poor respiratory monitor. It doesn't matter that that gap in neonatology may be positive or negative. So to be very clear, and I think this is a mistake particularly made in neonatology, the capnograph is an airway monitor at the point of tracheal intubation.
Great. Kirstin, I think you had the next question there.
Yeah, so this question's for Jan, and look, Tim's just briefly touched on it, but most of our focus today will be on the use of capnography to confirm correct placement of a tracheal tube. But what role does capnography have beyond this?
Thank you for the question. I mean, as Tim has previously alluded to, the value of capnography is vast, and I think as the decades have gone, we've, as a profession or as multiple professions, identified various uses in cases like cardiac arrest, for example, for hemodynamic resuscitation and guided resuscitation, but also thinking slightly broader as a tool for example, sedation. So anytime we're sedating patients, and even if we're not using a so-called invasive airway, it's a helpful monitor of respiration and adequate respiratory effort. So I think capnography has grown significantly over the past decades, and its uses continue increasing well past just as an airway monitor as such. But obviously, primarily, it serves as this. Yeah.
Okay, so it's really, I've just put up some stuff about the green zone from the vortex and what the Universal Airway Guidelines will call airway success, which is an identical concept, and really that as Tim sort of outlined, that the presence of getting CO2 back really confirms you have a patent airway and you're exchanging gas with the alveoli, regardless of what airway device you're using, whether it's a tube, face mask, supraglottic airway, or a front of neck airway. That it's useful for that confirmation. I've also seen that its use for, I thought this was interesting in the AAGBI guidelines for recommendations of standards of monitoring, is that they talk there about uninterrupted capnography monitoring should occur not just during induction of anaesthesia, but maintenance and during any transfers, including from the operating theatre to the post-anaesthetic care unit, and during emergency until the tracheal tube or supraglottic airway is moved. So what they're saying there is, and I think, Tim, you're an author on this, that it's not just about using it for initiation of airway management, but maintenance, discontinuation. And I think the thing there I'd like to just explore a bit more is its use for transfer. When I initially saw that, I thought that was a bit over the top. But when I thought about it, I thought the only reason I thought it was over the top is that culturally, certainly in Australia, it's not what we do. We would take the capnography off to wheel them out to recovery, and they wouldn't have capnography in recovery, even though there's potentially a supraglottic airway in place. But having thought about it a bit more, it makes a lot of sense. Did you want to expand on that use of capnography for us a bit, Tim?
Yeah, I think I wrote those words. I think that was part of the section that I wrote. And I think it's, so guidelines can sometimes be aspirational. They can sometimes be more than that. They can sometimes be, an expectation rather than an aspiration. And it's worth, so in NAP 7, so we've just completed NAP 7, which is so that guideline, that the idea that monitoring should be continuous from wherever the patient is induced. Many countries won't use anaesthetic rooms. Anaesthetic rooms are commonly used in the UK, but from where the patient's induced through to the point at which they are awake post-operatively. was in not just the most recent iteration of the minimum standards guidelines, but also in the previous one. I think it's probably the guideline that's most frequently ignored. We've just completed NAP7, which looked at perioperative cardiac arrest, and we identified, I think, about 30% of patients who are transferred post-operatively to recovery don't have particularly capnography in place. And these are patients who are unconscious, and it didn't vary by the airway device or by the level of consciousness. So unconscious patients who are supervised by a trained anaesthetist, anesthesiologist in theatre, who are then transferred unconscious to the care of a recovery nurse who may have less experience and perhaps less skill, who are then relatively unmonitored during that time. And capnography is frequently not used in recovery. And in NAP7, we identified not just that there was a gap in provision of monitoring, but also there were not a large number, but an acceptable number of cases of patients who arrived in cardiac arrest in recovery or developed cardiac arrest in recovery where the lack of monitoring meant that the recognition of cardiac arrest was delayed. And obviously, delayed recognition leads to the potential for poor outcome. And I think historically, as you say, Nick, there's a cultural issue. Well, it's just not what we do. I think it's become easier as monitoring has improved, and as so often in anaesthesia, we are supported by the technical benefits that our colleagues in manufacturing bring to us. And so a lot of machines will now have monitoring blocks that are easily detached from the back of the anaesthetic machine and then used they have a slave monitor, and you can use them for transfer and then dock them in recovery. And I think we should all be moving towards, or should have, that sort of monitoring, including capnography these days. And I have to say, in our hospital, we've struggled, but we are moving towards that. And I think within the next 6 months, we will be in that place.
It makes a lot of sense because, as you sort of say, you've got, we sit there and we wouldn't not have it on in a case with a supraglottic airway while the patient's fully anaesthetised and the anaesthetist sitting right at the head of the bed. But we wheel them out to recovery when they're waking up and coughing, and the anaesthetist now more remote, and that's the exact time we don't have the monitoring on. Kirstin, I think you were saying that you do use capnography.
And just to add, remembering that 1 in 4 in NAP4, I know it's a long time ago, NAP4, 1 in 4 major airway disasters happened either after extubation or in recovery, and it's less than that. Probably in recovery and transfer, but it's not a trivial amount. It's certainly more than 1 in 10, perhaps as high as 1 in 6 events are happening after we've left theatres.
Yeah, so I think certainly at where I work, we wouldn't have any monitoring on during transfer, and we don't have capnography in recovery. Kirstin, I think you were saying you have saturation probe on during transfer in your hospital?
Yeah, so our hospital has just acquired some monitoring blocks like Tim was alluding to, where, the patient disconnects from the machine, goes with the patient out into PACU. It's actually, we don't need a slave monitor, it's an all-in-one box, so you can see the pulse ox, the ECG and the blood pressure as you're transporting the patient, and then it just docks into PACU. There is the ability to monitor CO2 in PACU, but it's not routinely done.
Yeah. Ellen, Jan, what's your experience about capnography in transport and in recovery?
Not as readily available in transport, but definitely we are trying to get it universally in recovery. The problem is if there's a shortage or the nurse there sees a supraglottic airway device, they're very reluctant to use capnography. So that's a teaching. That's what we're trying to stress now. And I know of 2 incidents of negative pressure pulmonary edema because of a twisted supraglottic airway, an LMA, in fact, in young patients with a completely obstructed glottis, and then because they weren't monitoring the CO2, they didn't realize it was obstructed. So we're getting to a point where it's in every bay, in every recovery room now. But the transport, the monitor you mentioned that has the 3 on transport, the system, that's not available everywhere.
Yeah. So I think while it's certainly obviously very important for intubation, it clearly has roles with regardless of the airway device. And I know I think it's probably changing in the emergency department, but I've certainly in the past seen the emergency department set up to have the capnography connected to the tube ready to go when they intubate, but not there for confirming face mask ventilation. I think in anaesthesia we tend to routinely have it on for pre-oxygenation even before we start. I just wonder if anyone wants to speak to the benefits of introducing it early. Jan, what do you sort of see as the benefits of having it on in advance?
Just going back to your previous points, the last two trusts that I worked at in Manchester have had bricks, so you could monitor capnography as well. So they've been fairly well compliant. Saying that, I still remember the time, for example, in intensive care in a well-developed healthcare system in Iceland in 2018, where no patients had capnography even so late, which has since changed, but is surprising to say the least. In terms of having capnography on for prior to the induction of anesthesia, obviously to confirm that it's actually functioning, I think that's the main utility here, and we want to ensure that we have a functioning monitoring device before we use it, because otherwise we can get caught with our pants down at the most inopportune time.
So I've also got here from those same guidelines from the AGBI about use of capnography for sedation. And the other one that I thought was interesting, I think this was from one of the articles that came out as that salvo of articles in Anesthesia and Analgesia, Ellen, that you were involved in as part of the Global Capnography Project, that talked about use of capnography on the wards for identifying postoperative respiratory depression. And there was a line in there from a systematic review that the odds of recognising postoperative respiratory depression were almost 6 times higher in the capnography versus a pulse oximetry group. I don't know if you're aware of that study at all. I hadn't seen that, but it makes a lot of sense.
Yeah, that was from the American authors. We don't have it widely available in that context, but it obviously makes sense to have it in the respiratory wards. I mean, a lot of our face masks now, you can easily get the face mask with the connected capnograph. So there's no excuse, I think, not to use it in those high-risk patients.
So it sounds like even in the high resource setting, there's lots of work to be done in sort of aspirational work that we can make more use of capnography. Let's move on to the capnography, so-called capnography gap.
Nick, can I just briefly add?
Sure.
I think using capnography, I think if we just focusing on using capnography when the airway is tracheal tube, we're missing many tricks. So I think for training face mask ventilation, we know the inadequacy of chest rise as a metric of adequate lung ventilation. There's a grading of CO2 traces, which was published in the BJA about 5 or 6 years ago.
I've got that here. I'll put it up. Hang on.
Yep. And so I find that very useful for when teaching face mask ventilation. And there is a group of anaesthetists who are quite anti supraglottic airways traditionally, quite anti video laryngoscopy, because we're not treating the old traditional modes of airway management. And actually using capnography to monitor how well you or the trainee is managing face mask ventilation is really useful. And in real time, you can show the trainee how changing head and neck position from a sort of supine position to flextension, how changing perhaps from a double C, so from one hand to two hand, two person, and from changing V to a V position with the hands, how you can improve the quality of your ventilation. And reminding, of course, as you say, that if you're not seeing CO2, you're not ventilating the alveoli. And the same is true after supraglottic insertion, that you can assess, and I use a combination of capnography and spirometry, to assess the adequacy of the airway after ventilation and how it changes over time. So I think it's an invaluable and really powerful tool, both for patient safety, communication with your colleagues, and for training.
Great. And I've just put up there, I think that's the scale you were looking at, alluding to before, the Concord scale. It's actually from New South Wales here in Australia. And I've actually started documenting the outcome of face mask and supraglottic airway using this, because I think it's a very nice measure. I think the other thing you were saying about face mask ventilation is, even with pre-oxygenation, is, you know, if you're not getting a nice square wave, you haven't got a good seal. And I've actually measured sort of end tidal oxygen after pre-oxygenating with a mask loose enough that you lose a good capnography trace, and you end up just only giving them 40% oxygen. So it's a good measure of how adequate your pre-oxygenation is too, particularly in settings that don't have access to real-time end tidal oxygen monitoring. Okay, let's talk a bit about the capnography gap first in low resource settings. Kirstin, I think you had a question about that.
Yeah, Alan, you're involved in the Global Capnography Project, which provides equipment and education on capnography to low resource settings. Can you tell us a bit about that project?
Yeah, I suppose it kind of stemmed a little bit from the Lifebox Global Oximetry Project. I was lucky enough over the years to have been involved in some projects in low-income countries, Eastern and Southern Africa, over a number of years, and we did the first global oximetry audit, and in Uganda, in Kampala, and there was a huge oximetry gap which we addressed, and over a number of years, you'll all have been aware of those publications, and the kind of Lifebox project then, which was the next step to disseminate oximetry everywhere. And there was a lot of negativity at the time that they wouldn't work there, the probes wouldn't work, and so forth. But it kind of quickly became a reality. And then I also did a lot of work in Malawi, which is one of the poorest of those countries, and we did oximeterize Malawi successfully. So we then looked at the fact that we noticed there was maybe one, if no, capnograph functioning in some of the hospitals we were in. So we did an audit there. We looked at the gap, and capnography gap was 97% in operating theatres and 100% in ICUs. And this would be similar to many of those sites in that part of Africa. And the question then was, the equipment is more difficult. It's not as, it's not as robust, would never work. So we approached GE, and they gave us a donation of 40 capnographs with oximetry actually to take to Malawi. And we went to 8 hospitals and introduced capnography with a teaching package. Now, the teaching package was based on the work of Tim Cook and Fiona Kelly in Bath, because it was a nice, simple way of teaching capnography, the caps as hats, capnography teaching kind of package. But we felt we did more small group teaching. It was a more difficult sell than oximetry. I think it was easier to teach oximetry. So we also felt we had to go to the site. So there were 8 hospitals. We went into the sites, and we actually went into theatres and set up the capnograph, the capnography in the theatres. And we followed it up like we did before. 6 months later, we went back, we interviewed people, we went into theatres, and we did the follow-up. And they were very frank in their logbook follow-up, which we gave them, because they weren't used to kind of recording their complications, and usually nobody ever asked them kind of what was happening. And 77% of that cohort reported that they had an esophageal intubation would have been missed otherwise, and very, very high numbers, and 90% believed that it had saved lives, and they were very, very, very excited about this because, as I say, they have minimal monitoring. They use it in some of the ITU patients. They have a very small number of ventilated beds, but they use them there, and they can use them as a disconnect alarm as well, because they didn't have alarms and they had a lack of kind of personnel there. So this proved the concept, and it's the only study to date that has kind of done that. They picked up things like leaks and hypoventilation, severe bronchospasm and things like that. So there was kind of we did the critical incidents identified by the providers. So we published that. And then the next step is it's difficult to follow it up. We followed it up and say they were still functioning. Then we decided we do train the trainers in Uganda where they had more medical anaesthetists in Kampala. So we did that. We did the teaching with them, and that was kind of an easy process, and we didn't have to go into the theatres. And the follow up of that was dislodged by COVID. But the sad thing is, it's been very difficult to get the equipment, and GE didn't have any else to donate to us, so we got 80 in total. So we went then to kind of WFSA and Lifebox and said, Lifebox is doing well. We do see oximeters in most of these sites, but literally there's a huge capnograph gap, and we need something about it. So Lifebox have joined the WFSA and got Smile Train on board, because Smile Train is a huge charity that does a lot of surgery in 70 sites all over Central Africa. And so that's been our initiative now. So we have put out for tender like we did for Lifebox, and we have a capnograph which there were 7 and they looked at in total, and 1 has been chosen called the Zug capnograph, which we're doing a bit of pilot study on at the moment. It's been taken to Ethiopia. We haven't really got many of them on site yet, but that's the plan. And we put a trilogy of papers in anesthesia and analgesia talking about kind of the plan and how we're going to roll it out. But it's still early days. There are about, I think 10 of them have already gone there, but we think we'll just have to monitor their progress. I think it'll be slightly more difficult than introducing oximetry, but they are very keen on them, and once they have them, they really look after them because they see the benefit. So that's the plan at the moment, and it's nice that we have a consortium, a group together to push this forward. But it's going to be, I say, more difficult task than introducing oximetry, and probably more needed because, as I say, they have DLs, they have problems with their DL batteries, they had a shortage of tubes recently. So they really, a capnography would really make a huge difference to them, and it will save lives. There's no doubt about that.
So, Ellen, I've just got these, where is it? Hang on. These articles that came out in Anesthesia and Analgesia recently, if people want to scan the QR code, and otherwise we'll put them up on the website later if people want to download those. But there's a great lot of information there about the project and capnography in general. The capnography gap's not limited to low resource settings, though, is it, Tim? In NAP4 you found a gap even in the UK. I wonder if you could tell us a bit about that and the changes in the sort of what's been 12, 13 years since NAP4.
Yeah, I take my square wave top hat off to Ellen regarding the work that she's done in Malawi and other countries. And I think that there's an irony in that it's relatively easy and in real terms relatively inexpensive to implement universal capnography in high resource countries, and it will save lives in those countries, but actually it probably has the potential to save many lives in low resource countries, and that's probably a bigger challenge. But when we talk about esophageal intubation, which I'm sure we will later, unrecognised esophageal intubation, we are only really touching the tip of the iceberg in what we talk about. But that's not what you asked me about. What did you ask me about, Nick? Sorry.
Oh, I was asking you about the capnography gap in NAP4 in the UK and how that's changed since.
So that goes back to about 2011, when we did NAP4, which was, for those people that don't know, was a large project looking at major complications of airway management across the country in the UK. We identified that, particularly in critically ill patients, both the omission of capnography, failure to use, and misinterpretation of capnography was a key component in around 80% of critical events, airway events, so airway deaths, brain damage, need for a front of neck airway, or need for intensive care after an airway complication. And one of probably our key recommendations from NAP4 focused around increasing the implementation of capnography. And I think that's been a success in the UK. What was interesting was that and I think we're far enough away from it for me to be able to say this without having my knuckles wrapped. The senior intensive care organisations were not impressed by our recommendations. They said that there was a lack of evidence of robust randomised controlled trial evidence for the introduction of capnography to critical care and ED. And at the time, we think there was a little bit less than 50% of intubations of critically ill patients in the UK that had capnography on at the time. And what was very clear was that capnography was often taken off after that time. So the use of continuous capnography after that time was very much reduced. I'm pleased to say, and there were some senior intensive care organisations who said that it was not practical. We pointed out that given that 50% of hospitals were already achieving it, it clearly was practical. And in those cases where it wasn't practical, they perhaps needs to rethink that. And I'm pleased to say that there have been dramatic changes since then. And I fear that the UK, this may be one of the very few areas these days where the UK might lead the world. In as much as I think that capnography in all areas where intubation is undertaken or airway management is undertaken is pretty much a standard of care in the UK. It is a standard of care and it is largely implemented. If we look at studies in intensive care, in the emergency department, increasingly on wards, for instance, for cardiac arrests, including when a supracardiac airway is used, or intubation, and of course in anaesthesia. Probably the only place in the UK where it's not widely accepted is in neonatology, neonatal intensive care units. And in there, it's generally used for transfer, but often not used on the units. And I think that's where the gap exists in the UK. But if one looks at, there's a big study called the Intube study published about 4 years ago in, I think it was JAMA, and some follow-up studies. And that was a study of about 4,000 intubations of critically ill patients in around 30 countries. And the rate of use of capnography as the first choice for identification of tracheal intubation was about 25%, capnometry another 7%. And I guarantee that after intubation, many of those capnographs would have been taken off. So the actual use of capnography for continuous monitoring of the airway after intubation will be well below 20%. We do considerably better than that in the UK. We've just published the report, the findings from NAP7, and although we didn't focus on critical illness, there's some reasonable evidence to suggest that airway safety in general has improved in the UK in the last 10 years. What the causes of that are, I don't know, but I think it has improved. And I have been to a few countries where there is a existing view that the problems identified in BIT, NAP4, NAP5, NAP6 in the UK are simply a problem of the failings of the UK healthcare system. And my challenge is not to say that that's not the case, but always to say, well, actually show me your data from whichever country you're saying you don't have these problems. Until you've shown the data to show you don't have the same problems, I'm unconvinced.
Okay.
Can I just add to that,
Yep.
Nick? Can I just add something to that? Tim, you mentioned a few studies, but the device study, which was just last year on critical ill and emergency departments, I think they only used capnometry. I think they used 5 waveform capnographs in 17 centres. These massive centres in the UK in the US where they did the device study published in the New England Journal, VL versus DL. I mean, it's scary to think that in this day and age, in emergency departments and intensive care departments, they don't have waveform capnography. They tend to depend on capnometry.
Okay, let's get into the meat of it. We've talked about the wider use of capnography, and there's a lot of stuff to achieve both in low resource settings and high resource settings. A lot of aspirational uses, but the headline news is its use for excluding esophageal intubation, and we know that despite even clearly unrecognised esophageal intubation occurs in part due to failure to have access or use capnography. But if you look at the cases, there are still lots of cases of unrecognised esophageal intubation which occur despite availability and use of waveform capnography. So something else is going on in terms of interpretation and appropriate actions in response to abnormal capnography waveforms. What are the issues? I'll just throw this open to everyone. Why does it continue to occur even though we're using capnography?
I mean, that's the £1 million or dollar question, isn't it? And I think it might be a question of training. If we have access to it, it will be a question of what do we rely on when we have a situation that requires us to exclude esophageal intubation, or actually even thinking about it as excluding esophageal intubation in the first instance, rather than confirming tracheal intubation. And framing it as such is significantly important, because we should probably start thinking of having the default line being that we've not successfully intubated the trachea, and proving to ourselves and the whole team that is indeed the case using capnography. And in those situations where you have huge situational complexity, combined with maybe an learning deficiency in terms of how we interpret signs, there is a higher potential for an unrecognized esophageal intubation occurring, or an esophageal intubation going unrecognized, if you ask me.
Yep. While I've got you there, Jan, obviously one of the big issues is reliance on clinical signs, and you published earlier in this year, a systematic review and meta-analysis of the reliability of clinical signs for excluding unrecognized esophageal intubation, or excluding esophageal intubation. Do you want to tell us a little bit about the findings of that study?
Looked at essentially any study that compared clinical signs versus any sort of reference standard. Now, I'm not going to go into what the reference standards were. Mostly it was capnography, but sometimes it was something different as well. We looked at a handful of signs that gave us some data, but we essentially wanted to know if things like misting of when we put the tracheal tube in, or chest rise, or auscultation in various places on the body, have sufficient performance characteristics to allow excluding esophageal intubation, essentially. And for that, we did a diagnostic test accuracy systematic review and meta-analysis. Most of the studies, as it would be unsurprising, were actually historic, because this question has sort of gone out of favor with the advent of more ubiquitous capnography. So after the early noughties, you're not actually seeing many studies address this question, because the gold standard should just be the one that's actually used. And I think we're sort of dealing with the marginal gains here in the absence of a functioning capnograph. But these studies conducted in the late 80s or early 90s seem to indicate that misting and auscultation in particular have very, very poor performance characteristics. So I'm not sure if you have a graphic at all available, but it's quite startling to see that misting of the tube, that is when we give a tidal volume breath after putting the tube in, and the PVC tubing actually mists or doesn't mist. So that sign is actually worse than a coin toss, thinking about it. So we're looking at a false positive rate of 69% based on the studies that we looked at. Whereas auscultation doesn't perform stellarly either. So auscultation has been described as either using auscultation in the axilla, or anteriorly in the axilla, or combining it with epigastric auscultation as well. Now, those signs tend to have a false positive rate of 14 to 18% based on our data. And one would argue that in isolation, this is definitely insufficient. And you could also make an argument that even if you combine it with other signs such as misting, such as chest rise, or other clinical indices, it would never be sufficiently specific to exclude esophageal intubation.
So just to summarize that, roughly 70% of tubes that are in the esophagus would have misting, despite being in the esophagus, and about 20% of tubes that are in the esophagus would have breath sounds. Would have breath sounds despite being in the esophagus. So there'll be, basically, if you were to use them to determine to exclude esophageal intubation, you'd be wrong 1 in 5 times with auscultation and 70% of the time with misting. So this is the I think this is the
caveat, the heterogeneity of the studies. But yeah,
sorry, say that again, Jan.
I just wanted to say that this needs to be caveated with the fact that these studies were slightly heterogeneous in the sense that some of them were performed in the pre-hospital space or the in-hospital environments. So you have a bit of variability there.
Yeah, that's true. But also those studies are, a lot of them are, they've intubated the esophagus and they've intubated the trachea, and then got people coming in potentially knowing the purpose of the study to listen without time pressure, without noise, without panic, without any investment in saying, I'm sure I put the tube in the right place. So you could argue that these are the best possible performance of sort of auscultation is 1 in 5. I'll just show you here. I've got a hang on. I'm terrible at multitasking again. Just got a picture from this study in the Indian Journal of Anesthesia. This came out a couple of months ago. This is a prospective observational study of esophageal of ICU patients, and I think they were comparing auscultation, capnography, and ultrasound for confirming the tube. They had quite a high esophageal intubation rate of about 8%, I think. But for them, they got positive breath sounds that would have suggested the tube was in the trachea in about 70% of esophageal intubations. So whilst it might be 20% in an experimental setting, it's not surprising that in a clinical setting where you've got other factors in play, that the amount of time people hear breath sounds despite the tube being in esophagus is even higher. And then if you look at the incidence in real cases, then in 100% of cases in which esophageal intubation is unrecognised, they heard breath sounds, which is a biased sample because that's part of why it was unrecognised. They heard breath sounds and left the tube in. But it goes to the danger of relying on clinical signs. And I suppose the thing I want to bring up is that this ended up being the most controversial part of the whole preventing unrecognised esophageal intubation guideline, and we've had a lot of correspondence about this. I just wondered if Tim or Ellen or you, Jan, want to address this, because I think all the correspondence seems to boil down to 3 things. One is, I don't think we should stop doing clinical examination at all. The other is capnography can still be wrong, and the other is I wouldn't use the clinical signs in isolation. I would perform an integrated analysis and use all the available information. They seem to be the main criticisms, that people are very reluctant to give up clinical signs. I just wondered if any of you want to speak to those issues.
Can I touch on that briefly? But first I want to just go back. You said, why do these events happen? I think one of the problems. So Jan focused on education. I'd focus on humans being humans. So I think we're designed to a certain extent to see what we expect to see, and I'm sure Jan will give us some education about Bayesian I wasn't going to necessarily talk about, but talk about Bayesian statistics, etc. But I think one of the problems is that we get intubation right most of the time. So my trainees hitherto have frequently said to me, "I've got chest rise, I've got a misting in the tube. I'm going to look at the capnograph." And now they get a rude retort if they say it in that order. And they get asked not to do that. And I've taught myself quite rapidly not to think in that way at all. I just look at the capnograph with a colleague. But because we are successful in intubation most of the time, we will see apparently see chest rise and apparently see misting of the tube, and so we will associate those with success. And on the rare occasions that we are incorrect, we probably don't focus on the signs that occur. But I mean, one of those signs will be 8 times out of 9 misting of the tube. So it's a non-discriminatory test. So it's a pointless test. But because we are successful in intubation most of the time, we're not very good at recognizing the problem. And the order of tests that we do things in is also problematic. So if we start by, let's say, looking at misting of the tube, then whether it's in the right place or not, we'll most commonly see it. And that will that will anchor us to a view that we're in the right place. And then the subsequent tests can reinforce that view. So we become ever more certain that we're in the right place, even though those tests are unreliable. And then we look at the capnograph and we see that it's flat. And we say, oh, what's going on here? All the other tests are telling me this is okay. It must be okay. Whereas actually the other tests are unreliable. And we end up then making an erroneous interpretation of the capnograph and looking for excuses as to why it might be wrong. Whereas if we start by saying, just focusing on the capnograph, and I think as you said on Twitter recently, that's the end of the conversation, then we're much more likely to get it right and much more likely to identify those errors quickly. If we then throw in a clinical situation where the patient's desaturating, becoming tachycardic, we're not sure what's happening, they may have regurgitated at the same time, and we have a clinical crisis, then our clinical behaviour, whoever we are, starts to deteriorate. We become tachycardic, we start to question what we're doing, and it's well recognised. It's a shame Fiona wasn't able to be here, but she'll be able to explain how our working memory deteriorates and how our physiology deteriorates and our performance declines.
And as an airway assistant, Tim, Stavros in the comments has put, he wonders if there's an issue of doctors wanting to feel skilled rather than relying on a machine to tell them what's right or wrong. I very much feel, from my observation over nearly 20 years, that doctors are always right. And they don't like to be told they're wrong, or at least most of them don't. That's actually getting better as the younger generation come along, but I definitely think there is an element of relying on those skills that tend to prove them right, rather than capnography, which actually might be proving them wrong.
Yeah, and I think that's one reason we started a project in our large hospital where all the assistants, and mainly anaesthetic nurses, are trained now to verbalise whether the sustained exhaled CO2 and adequate SaO2 are present after intubation. So they get teaching, they get video, they do simulation Friday mornings in the recovery room with the recovery staff as well. And it's been successfully rolled out, and it's going to be rolled out hopefully through the Airway leads nationally now, because I agree. And I think also, instead of saying we see misting and chest rise, which some of our assistants used to do as well, they're now saying this and they're empowered to, and it's become the norm. But that was kind of thanks, I think, to the the guidelines, the POI guidelines, and that's, I think, the way forward.
Jan?
I fully agree, and I think it's an excellent effort, Alan, to empower the entire team to be part of the whole journey and to have the skills to recognize when things are going wrong. This might be a bit of a fatalistic view or comment, But I think this taps into human nature. I think Tim referred to human nature initially when he started his bit. And my concern is that there will always be a situation where somebody has that sort of level of hubris where they're not willing to admit that they've potentially put it in the wrong hole, and that's what we need to actually be tackling if we're hoping to succeed. I think intentions are good in a lot of these cases that unfortunately end up as unrecognized esophageal intubation, but there is also that potential for somebody just not listening to their environment, and we still have considerable hierarchical gradients in our systems of care. In spite of all of our efforts. So I agree with Kirstin here, actually, that we need to do more and we need to do better on this front.
Tim?
So two things. We've done some work on this. Fiona Kelly and I have introduced in the IUH, the hospital I work in Bath, and we've done some work with Guy's and Thomas's in London. And we now try and do two-person dual checks. So we use universal video laryngoscopy. So our anaesthetic assistants or anaesthetic trainees, we expect two people to confirm that they've seen the tube pass between the cords and anterior to the retinoids. And the anaesthetic assistants are now experienced at looking at airway anatomy and recognising that. And then secondly, we all check for, and I really don't care whether it's 5 or 6 or 7, it's sustained exhaled carbon dioxide. And it doesn't matter if it's 7. If it's 7 and then it drops off, you need to start again. It needs to be sustained, maintained exhaled carbon dioxide. So that two-person check, each individually and independently. So it's not, I saw the tube go through the cords, do you agree? It's, what have you seen? I've seen the tube go through the cords. I've also seen the tube go through the cords. I've seen 7 waves of capnography. I've seen where we can confirm that we have intubation. That actually, not only does it improve the safety for that patient, but it changes the culture. It allows anaesthetic assistants to be a much greater part of the team. We've always said that video laryngoscopy changes intubation from me to we. But Fiona Kelly talks about listening down and speaking up. We now have anaesthetic trainees who will cuss their seniors. Cussing seniors means that if they have problems, if they feel that the anaesthetist is undertaking unsafe practice or making a mistake, they'll explain that they're concerned. They'll say that they're unhappy. They'll then say there's a safety issue, and then they will say they are going to ask them to stop while they get someone else to help. So that's concerned, unhappy, safety, and stop. So cussing their seniors, not their seniors, their colleagues. And that culture has changed, and our anaesthetic assistants do this, and it makes it safer. We don't work as individuals, and that, as Jan says, that hubris needs to disappear.
I think it's not just hubris, though. I think there's also a sense of, as I've heard you say many times, Tim, that these things happen to good people, skilled people and people who are behaving well. There's also just a degree of conditioning, isn't there? The more experienced you get and the less often you put the tube into the esophagus, your experience is that it's always something else. I've seen this before. It's always something else. So you're just exposed to more incidents of it being something other than esophageal intubation. Jan, and I'll just get you both to have a look at these comments there that are just leading to, again, just about the integrating. I think they're getting a little bit at integrating clinical signs with CO2, which I might get Jan to speak to after he's made the comment he wants to make. Go, Jan.
Sure. Yeah. Thanks, Nick. I just wanted to circle back to Tim's idea of the anatomy of death by esophageal intubation, and once the patient sustains a cardiac arrest, we will be in a position where it's extremely difficult to come back from this, to recognize this. Seeing specifically where we just start focusing on various other issues, like you said just earlier, it must be something else. When that patient deteriorates sufficiently to that extent, it's extremely unlikely that by that team not introducing somebody else coming in fresh and potentially recognizing the situation will be able to make the diagnosis. And things like crowd control become an issue as well, and all sorts of human factors. Just you sort of tweak it up to 11 if to use a dated reference, but yeah.
I think yeah, and you and I have discussed too, and I've found that in the now more than 12 months since the guidelines come out, one of the toughest things to get across is not the recommendations themselves, but getting people to have the insight that they need the guidelines. That there's the sense that there's a bit of guideline fatigue, but there's also a sense that exception bias. This happens, but not to me, and to getting people to realise that they're vulnerable to making these sort of errors. I wonder if any of you we've talked a little bit about teaching, have come up with ways to make clinicians realise they're vulnerable. Because to me, when I've found that's the sort of first step to get people to buy in and listen to you in the first place.
I think if you work in a place where there's a culture of mutual respect amongst people who work together, and so we've had universal video laryngoscopy in Bath for about 8-10 years. We anaesthetise all our patients in theatre, and it means to a certain extent that, and we have airway workshops which trainees may teach consultants on, and consultants may teach trainees on, and everybody has to go to. So what it means is that everything's out in the open. The trainees see the senior anaesthetists anaesthetise and teach, and they see their frailties, and the anaesthetic assistants the same, and vice versa. And I think when you have that openness, then it becomes easier for people to say, I don't, I'm not used to using a D blade. I don't quite know how to use it. Can someone teach me? As some of my senior colleagues and junior colleagues have said, and we each have to learn new techniques. So I think if you work in a culture where things are more open, then airway management in general is going to be more safe. I know we're reaching the end. I think a really important thing to emphasise before we move on from clinical science is that the guidelines and the whole thing about capnography and the meta-analysis, so the meta-analysis and clinical science is, nobody is saying clinical signs are not of value. What the message is that clinical signs are of almost no value, and are not clinically useful in excluding esophageal intubation. They're actually very useful in identifying or confirming esophageal intubation, and they have other roles, but they're not useful in excluding esophageal intubation. And if your capnography does fail, yes, capnography does fail, try and identify the reasons for it. But in those circumstances, the way to then identify whether the tube whether your capnograph has failed or you have a flat or abnormal capnograph, the way to confirm whether or not you have esophageal intubation is to use one of the validated 3 methods, which is ideally a 2-person repeat video laryngoscopy to confirm tube position, bronchoscopy, ultrasound in skilled hands. So the laryngoscopy combined with either bronchoscopy, ultrasound in skilled hands, or not for the first time use of the Mike Wee esophageal detector device.
Yeah. And this has become much easier now with the availability. Every theatre now has available ambuscope immediately available, or they can use the Stort's disposable with their GC Max. So I think that's become much easier, and that's something we're using a lot more now as well. Just checking the tube just to be sure.
You've just reminded me with that. I know no one here is involved in sponsorship, but I was supposed to show an ad that I've forgotten to show, so I'm going to show that very quickly. Sorry. Okay, so yes, not that I'm being paid for sponsorship there, but those sort of units where you can plug a disposable bronch into your video laryngoscopy make that whole confirmation thing much easier. That wasn't a promotional thing, that just reminded me. We're running out of time. I just want to wrap up. The last thing I just want to deal with is Jan, just your study, the Bayesian logic stuff. So we've talked about, we're not saying don't ever use clinical signs, just don't use them to exclude. We're not saying that sometimes you'll pull out the tube unnecessarily. That's fine. I think with when we don't have a perfect test, precautionary measures require you to be wrong some of the time, but that's not going to do the patient any harm. Usually pulling the tube out is not going to do the patient any harm, and if you think it is dangerous, the guidelines allow you to put a bronch down. But one of the other resistances is, you've looked at these tests individually. I would use them as an integrated whole. And we've already talked a little bit about how in some ways that integrated use can set you up for a fail, because you end up with 4 bits of information which you intuitively give equal weighting, and the capnography is one of these things is not like the other, and so you think, well, that might be wrong. But you sort of looked at this a bit more formally, Jan, in a study. Do you want to just tell us quickly about that before we wrap up?
So I'll start. Thank you, Nick. I'll start with a couple of caveats. So I wouldn't say that I looked at it formally. This was a very, very informal letter, actually, where we just presented 2 situations where, regardless of what the prevalence of esophageal intubation is, you can adjust your prior beliefs based on the likelihood ratios that we've identified in our systematic review and meta-analysis, and derive from that your posterior beliefs. So in essence, using a Fagan nomogram. And if you're coming from a position of being quite certain that you're in the right hole, and if you're unfortunate enough that you're actually not in the right hole, which is a rare situation actually, and then also being unfortunate enough to have false positive misting and false positive auscultation, then you will erroneously increase your post-test probability of tracheal intubation, or the exclusion of esophageal intubation, to the point where it's dangerous, because you're then primed and you've anchored to that extent. Even if you start from a 50-50, so you're saying, okay, I might be in the wrong place, but then if you, again, unfortunately, you see misting, and unfortunately you hear breath sounds and auscultation, this still raises your post-test probability erroneously, and herein lies the problem. And our systematic review and meta-analysis obviously didn't do this in a codified fashion, or compare the tests in sequence. But even if you do serial sensitivities and specificities, more importantly specificities, you still don't reach a sufficient false positive rate, or a sufficiently low false positive rate for this to be enough for us to exclude esophageal intubation. And it just goes back to, what are we trying to do? So if I'm trying to raise my suspicion of esophageal intubation, clinical signs are great actually, but they just don't work for excluding esophageal intubation. That's all.
So I'm not a stats guy at all, but even without that formal analysis, the integrated use doesn't make sense to me. If you take something like breath sounds, which are going to be wrong 1 in 5 times, and you combine them and say, but I'm going to combine that with misting, which is wrong most of the time, I just don't see how you can come up with a better answer.
So there is an interesting study. It's tricky. You can't realistically just combine them, because the likelihood of one being wrong and the other also being wrong is lower than one being wrong and the other being right, and it bails you out essentially. But you don't know what those likelihoods are in a given scenario. So I think it's an unfair comparison doing those in sequence. Saying that, if you add additional tests, let's say a 3rd test and a 4th test, that would then take out those cases where the first 2 didn't capture them, you might foreseeably come to a situation where you only miss 1, for example, but you're still missing that 1 is the problem. And no amount of clinical signs, if you scale all of this up, will give you the sum total of perfect, and that's the issue.
But I'll give my final message, and then to wrap up, I'll get everyone to give their final take-home message. But following on from that is that it doesn't need to be perfect. You know, it could be great if we had something that was perfect, but if you end up pulling out the tube in a situation where that's not dangerous, or you go through the motions of checking with a bronchoscope, no harm is really done by that compared to the catastrophe of missing an esophageal intubation. And for me, you know, it's a bit this. The same applies to sort of airway evaluation, risk evaluation for airway. If you do an awake tracheal intubation, then find out whether a grade 1 laryngoscopy afterwards, it's not a drama. You know, the thing is, we don't have accurate tools to predict these things. And my message is always, it's more important to be safe than it is to be right. And I think I often have people say to me, I had this case where insert other cause of absent sustained exhaled CO2, and so removing the tube would have been wrong. And I think those people have missed the point, is that we're not saying that absence of sustained exhaled CO2 guarantees an esophageal intubation. What we're saying is that an unacceptable risk threshold has been exceeded, and what it does is mandates that that's excluded, either by removing the tube or by one of the valid alternative techniques if you think removing the tube would be dangerous. I'll just go around and ask each of you. I'll start with Tim. What the final message you want to give people about capnography and esophageal intubation is?
Yeah, it is the human is in the middle of this, and a lot of it is about human factors. Fiona's very good. She's led on guidelines that have been written about human factors, and if you want to synthesize those into if you want to break those down into a very short message, then it's that improving design and creating barriers are far more effective than having mitigation, and more effective than education and training in preventing problems. So something like the NR Fit changes to preventing inadvertent neuraxial, wrong route neuraxial injections are a good example. We probably don't have a perfect design solution to prevent this, but things such as standardizing monitoring, changing so the order in which parameters or variables appear on a monitor, certainly throughout a hospital, possibly across just standardized for everybody, having a CO2 trace which is filled in, and then having safer systems such as our colleagues checking with us when we intubate, both with video laryngoscopy that we've intubated and capnography that we're ventilating the lungs. And then if we're uncertain, having a SOP that we use, and the Puma guidelines are an excellent SOP to use to create that. And those form, I think, to a certain extent, design changes and barriers which will lessen the likelihood of unrecognised esophageal intubation.
Great. Ellen?
Right. Read the guidelines. They are fantastic. There are 11 recommendations, and implement them. And the first recommendation is capnography and pulse oximetry should be available and used for all episodes of airway management. That must become a reality. And I think global capnography, we say whenever feasible, but I think it is feasible. And I think we should and can get capnography to everyone where airway management happens. And I think we have an obligation to do that. So please support global capnography universally and watch this space. We will hopefully have this low-cost capnograph, which we will hopefully disseminate throughout the world.
Jan?
I will just finish on a different note. Guidelines are amazing, and we need to follow them. And I think what's exciting about the future is that we're in the space of marginal gains right now when it comes to esophageal intubation. We need to see how guidelines will shape clinician behavior over the next 5 to 10 years, these guidelines that are coming out now, because part of me is a bit concerned about unintended consequences. You know, one of the reflections that I've heard from the preventing unrecognized esophageal intubation guidelines is the fixation on 7 exhaled carbon dioxide waveforms. And clinicians have a strange way of using things as targets or as fixed targets, and then you might be potentially neglecting a very low blood pressure because you're waiting for those 7 breaths and you're counting them. So I think the human mind, has a very perverse way of distorting useful information, if that makes sense. I know it's a bit of a bleak note, but I'm hopeful that we can find a way to reconcile this in a manner that's congruent with safety.
I think what the point you're raising addresses is that you can't just publish guidelines and expect practice to change. You need education programs to translate the guidelines into clinical practice, like Tim and Ellen have spoken about, and address those sort of questions. I've run training sessions around it, and these sort of questions come up. They're easy to address if you have the session where people can talk one-on-one and you can give appropriate weight and explain the practical implementation of these things, and also get them just over the self-consciousness. Tim talked about and Ellen talked about the verbal confirmation and getting assistants to work together. Part of that is it's a change in culture. And you just need to normalise that, and training and things can be useful ways to do that. So I think Puma's put together, for all our guidelines, we're having an education program to translate them into clinical practice. And I think the esophageal intubation program should roll out this year, is nearly completed. Kirstin, did you have anything you wanted to comment or ask, particularly from an airway assistant perspective, about all this?
Just a comment, really, to any airway assistants watching. Always, if the CO2 monitor is available, use it, know what it's useful for, and know how to speak up about it appropriately when you see something that isn't right.
Yep. That's a great note to finish on. And we again, part of that training program is empowering assistants to feel able to speak up when they feel that something isn't right. Because I think in many of those cases of unrecognised esophageal intubation, someone has spoken up at some point and said, is the tube in the right place, and has been ignored, and that's led to catastrophe. I'd like to thank all of you for joining us once again. Sorry we've run over a bit. I would just like to again thank our sponsors. Hang on, I've got to get on the right screen to do all of this. I've made my life very difficult here. Anyway, thank you to Jan, Tim, and Ellen for joining us. It's been great. The time has gone way too quickly. I'm sorry for running over. We would just like to again thank our sponsors, who are Verathon and Lateral Medical, for helping us out today. If you want to continue the conversation on Twitter, then please use the hashtag Airwaves CO2, and you've seen Ellen and Tim and Jan's Twitter handles up there, so you're welcome to harass them about anything you want to argue with them about over the ensuing week. That's all we've got time for. It's been great talking to everyone. We've really only touched on the human factors side of things, I think, but we'll talk about this again. Thanks, everyone. Have a great Christmas holiday. And we'll see everyone in the new year.